You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 30th, 2024. This week, I'll have 4 Friday studies from the European Society of Cardiology meeting. This will include studies on post-MI beta blockers, a new therapy for ATTR-cardiomyopathy, the strategy of holding or not holding renin-angiotensin system inhibitors before non-cardiac surgery, a good news meta-analysis in heart failure with preserved ejection fraction, and some more previews from ESC. So this morning, Professor Johanne Silvain presented results of the ABYSS trial, comparing beta blocker interruption versus continuation at 1 year after an MI. Beta blocker stoppage after MI is obviously a hot topic in cardiology because this spring at the ACC meeting, we learned the results of the reduced AMI trial. This was a Swedish RCT which compared beta blocker usage right after MI to no usage. Reduced MI enrolled patients with a normal ejection fraction, and they reported no difference in the primary endpoint of death or MI, though the confidence intervals were wide, ranging from a 21% reduction to a 16% increase in events. Now, before I say anything about the details of the French ABYSS trial, I should set out that the data supporting post-MI beta blockers is extremely old, way before PCI, and it's pretty weak. So our pre-trial priors of ABYSS should be that discontinuation of beta blockers at 1 year should make little difference. And remember, friends, trials never give an answer. Rather, they modify our pre-trial beliefs, much like medical tests do. Now, ABYSS had a few differences from the reduced AMI trial. First was that you could be randomized with an EF greater than 40%, whereas in reduced AMI, you had to have a normal EF. Now, the actual mean LV ejection fraction in the ABYSS trial was normal, however, at 60%, and the number of patients with an EF between 40 and 50% was only 23%. So less than a quarter of patients in ABYSS had even a mildly reduced EF. Another difference in the two trials was that the interruption came at 1 year, but not right away after the MI. But the biggest difference, I think, was the primary endpoint. In reduced AMI, it was simple, death or MI. In ABYSS, it was not simple. It was a composite of a lot of things, death, MI, stroke, or hospitalization for any cardiovascular reason. And I'll come back to that last endpoint. The ABYSS trial, like the reduced AMI trial, was open label, so patients and caregivers knew the treatment group. The top-line results seemed to contradict reduced AMI. In ABYSS, over a 3-year follow-up, which is a pretty strong degree of follow-up, a primary endpoint occurred in 23.8% of the interruption group versus 21.1% in the continuation group. The upper bound of the 95% confidence interval here was 5.5%. So the absolute risk difference, 2.8% higher rate of bad things, corresponded to a relative risk of 16% higher. The hazard ratio in relative risk was 1.16, with a confidence interval that went to 1.01 to 1.33. So worse with interruption. The authors also did a quality of life assessment and found, surprisingly, no difference. The study authors had chosen a non-inferiority assessment and a 3% absolute risk increase as the non-inferiority margin. Since they estimated the event rate in the continuation arm of 12%, that corresponded to a 25% relative risk margin for non-inferiority. and the upper bound of the rate of the events in both absolute terms and relative terms. The worst case scenario did exceed the non-inferiority margin. In other words, there were more events in the interruption arm, and ABYSS did not make non-inferiority. It seems to contradict the reduced AMI trial, but let's look closer at the results. I think that a look at the actual primary outcome events tell a different story. Recall that reduced AMI looked only at death and MI, but ABYSS had 4 components: death, MI, stroke, or hospitalization for a cardiac reason. In ABYSS, the rates of death were 4.1 and 4.0, so no difference in death rates. The rates of MI, 2.5 versus 2.4, so no difference in MIs. Stroke, 1.0% in both arms. The cardiovascular hospitalization rates is where the difference came, 18.9 in the interruption arm versus 16.6% in the continuation arm. Now, think about it. Had ABYSS chosen the same endpoint as reduced AMI, it would have got the same result. Now, the most common cause of hospitalization was, quote, coronary related, and in that category, the 2 most common were for angina and angiography were the major drivers of the cardiovascular hospitalizations. Now, I would remind everybody that ABYSS was an open-label trial. By email, my friend, Dr. Bogdan Inaki, a person who you should be following on Twitter, he wrote to me that this being a French trial may explain the higher rates of angiography in the interruption group. Bogdan practiced in Monaco for a few years, and he wrote that, quote, French patients are followed up by outpatient cardiologists who are traditionally seen as cardiologists who refer their patients for a lot of angiographies. And then, if you consider that this is an open-label trial, there may be more angiographies in patients who had their beta blocker discontinued. So my final conclusions is that the results of ABYSS may appear different from reduced AMI, but clinically speaking, I think the 2 trials are quite similar. If you count only strong clinical endpoints, death, MI, stroke, both trials show no harm from either not using beta blocker or interrupting the drugs at 1 year. The driver of beta blocker interruption, missing non-inferiority in ABYSS compared to continuation, was a bias-prone soft endpoint, I think, of minimal clinical significance. And of course, I respect the idea that trials should be interpreted strictly given their primary endpoint and trial procedures, and that's the way it will be in the New England Journal of Medicine. But that strict scientific interpretation need not affect the clinical translation at the bedside. I think I will continue to stop beta blockers in post-MI patients who have no other important reason to be on the drugs, if for nothing else to decrease pill burden. All right, next topic is on ATTR cardiomyopathy. This is the HELIOS-B trial, also published in New England Journal of Medicine. This was a regulatory study studying the drug vutrisiran, V-U-T-R-I-S-I-R-A-N. This is a subcutaneously administered RNA interference therapeutic agent. It inhibits the production of hepatic transthyretin. It's given as an injection once every 3 months. The company that makes the drug issued a press release earlier this summer saying that HELIOS-B delivered positive results. And at that time, Sue Hughes, journalist from the Heart.org, Medscape Cardiology, has a really nice coverage of the press release, and I'll link to her coverage. She tells us that vutrisiran is already available in many countries for the treatment of amyloidogenic mutated transthyretin-related polyneuropathy, which is not as common as the cardiomyopathy complication. Sue Hughes also reminds us that transthyretin-mediated amyloidosis with cardiomyopathy results from the aggregation and deposition of transthyretin amyloid fibrils in the heart and various tissues. It's a progressive disease that is ultimately fatal, and it's an impressive infiltrative cardiomyopathy on echocardiography. Now, in fact, vutrisiran is approved for ATTR amyloidosis with polyneuropathy on the basis of the HELIOS-A trial. I'll link to that. A sub-study of that small trial suggested potential cardiac benefits. The authors found that the drug lowered BNP levels. Now, one more background point. ATTR cardiomyopathy occurs as a result of inherited TTR gene variants, hereditary or variant type, often with a mixed phenotype that also includes polyneuropathy, or it can occur with aging in the absence of predisposing TTR variants, so-called wild-type ATTR amyloidosis. So HELIOS-B was a placebo-controlled trial. It was vutrisiran versus placebo in 655 patients with ATTR cardiomyopathy who had a history of a heart failure hospitalization. About 40% of both groups were taking tafamidis. Average age of patients, 77, 92% male. The primary endpoint was a composite of death or recurrent cardiovascular events, which included hospitalizations for cardiac causes or urgent heart failure visits. Secondary endpoints included death, the change from baseline in the distance covered on a 6-minute walk test, or the change from baseline in the KCCQ score. The trialists broke up the groups into vutrisiran versus placebo in an overall population and vutrisiran versus placebo in the monotherapy group that was not on tafamidis. And the main results over a trial period of 36 months were positive. In the overall population, a primary outcome event, death or CV event, occurred in 38% versus 48%, an absolute risk reduction with vutrisiran of 10%. The hazard ratio, 0.72, confidence interval 0.56 to 0.93. Death, too, was 31% lower. Recurrent cardiovascular events, 28% lower. So both of the components of the composite primary endpoint were positive for vutrisiran. Results were similar in the monotherapy arm as well. Very similar hazard ratios and confidence intervals. The Kaplan-Meier curve started diverging after about a year and continued to diverge. Both the 6-minute walk test and the KCCQ declined over the trial period in both groups. In other words, patients progressed. But the median changes were less in the active arm. Similar patterns were seen in both the overall population and the group on tafamidis. There were no differences in adverse effects. So my comments. Of course, I am not an amyloid expert, but this seems like a clear win for the drug. It had a death reduction along with recurrent cardiac event reduction. It had a slower decrease in functional and quality of life measures, and there were no differences in adverse effects. It's impressive that there was a benefit on top of tafamidis, which also has documented benefits. The company plans to seek approval for this drug for this indication. Now, one specific issue noted by the authors was that tafamidis was allowed background therapy at baseline, and patients were not randomly assigned. Therefore, this trial does not allow for randomized comparison of vutrisiran alone with tafamidis alone. I think this is an important thing to say because I can imagine when a new patient is diagnosed, the question will be which drug to start. Given that they both are likely to be quite costly, there will be tension not to use both drugs. I think there's a lot more to learn with this condition, but I can't seem to find any major issues with this trial, and this seems like a breakthrough to me. But if you know more about it and think there are some weaknesses that I missed, please do let me know. All right, third trial, also at ESC, is called the Stop or Not trial. I really like this trial because it's a pragmatic trial that answers a specific clinical question that comes up some. This is the comparison of stopping renin-angiotensin system inhibitors, RAS inhibitors, 48 hours before a non-cardiac surgery versus continuation of the drugs. It turns out that French guidelines recommend holding RAS inhibitors before non-cardiac surgery, while AHA guidelines say continuation is reasonable, and they give it a 2A level of recommendation with B level of evidence. What's more, and I think this adds a nice little twist to it, there is an observational study of 4,800 patients who had non-cardiac surgery. I'll link to this study. The authors of the observational study found a strong association of benefit, lower rates of death, stroke, or MI, from holding RAS inhibitors 24 hours before non-cardiac surgery. They found a hazard ratio of 0.82 and a p-value of 0.001. They also found a higher rate of intraoperative hypotension in the continuation group. The authors of that observational study concluded that there was a strong association of benefit, but a large RCT is needed to confirm this finding, because there may be confounding in this non-random comparison, and I say good on the authors. The first author of that observational paper is Dr. Pavel Rashanov. Before I tell you the results, I want to say that I often hold blood pressure medicines the day before an AF ablation so as to avoid soft blood pressure during and after the general anesthesia. Now, this study was done in more than 30 French centers. One group got RAS inhibitors held for 48 hours before surgery, and the other group continues the drug. The inclusion criteria included serious surgery. Now, this had to be surgery lasting more than 2 hours, and you had to have an expected hospital length of stay at least 3 days. The primary endpoint was death or major post-op complications within 28 days, and the list of post-op complications was quite long and involved lots of bad things that I won't go through the entire list. And I think the results of this trial are quite straightforward. The authors randomized 2,200 patients, half discontinued, half continued the RAS inhibitors, and the rate of the primary outcome, that is death or surgical complication, was 22% in both groups. The confidence intervals were pretty tight at 0.87 to 1.16, so we can say pretty confidently that there was no significant difference. The authors did note a lower rate of intraoperative low blood pressure, 41% versus 54%, but this intraoperative hypotension did not translate into any serious complications. The conclusions of the trial was that since there were no differences, both strategies of holding or not holding were acceptable. This means clinicians have greater flexibility in managing preoperative RAS inhibitors, and they can base it on individual characteristics. And I would like to commend the authors of this trial. First author is Dr. Matthew Legrand. JAMA has published a manuscript, and the trial answered an important question. I think we need more of this kind of work. Everyday practices ought to be tested. And the great thing about the results is that it gives clinicians evidence regarding choices regarding RAS inhibition before surgery. In general, there's no compelling need to hold RAS inhibitors in the average patient. I would tend to do the simplest thing, and I would continue the drugs in the average patient. But if you have particular concerns, there is no reason not to hold the drugs. There is no harm. And now we have high-level, randomized, controlled trial-level evidence. All right, next topic concerns heart failure with preserved ejection fraction. This is a tough condition to treat. There are approved medications like sacubitril/valsartan and SGLT2 inhibitors, but you know, I've talked about this before, the strength of that data is not anywhere near as strong as it is in patients with heart failure with reduced ejection fraction. And many patients with HFpEF also have obesity. And in recent years, we know that the GLP-1 agonists show great promise in inducing weight loss. So might the GLP-1 agonist also be heart failure drugs? Last year at ESC, I covered such a trial called HFpEF. It was a small trial, semaglutide versus placebo, only 529 patients with HFpEF and obesity. The primary endpoints were soft and included just KCCQ and weight loss. My column at the time said that semaglutide cleared a low bar. It did this because these were subjective endpoints, and surely those on the drug came to know their treatment assignment. And then if you don't have placebo control in a qualitative endpoint, you have a problem. So if we were going to use GLP-1 agonist in HFpEF, we had to have outcomes data from a big trial. At least that was my argument. Well, we don't quite have that yet, but at ESC, authors from 4 trials involving semaglutide have published a patient-level meta-analysis taking HFpEF patients with obesity and measuring the standard heart failure endpoint, cardiovascular death, and heart failure hospitalization. The 4 trials included STEP-HFpEF, which was semaglutide versus placebo in HFpEF patients with obesity, STEP-HFpEF diabetes, which semaglutide versus placebo in HFpEF patients with diabetes and obesity. And then remember the SELECT trial, which was semaglutide versus placebo in patients with established vascular disease and obesity. and the FLOW trial, which was semaglutide versus placebo in patients with CKD and diabetes. SELECT and FLOW did not require obesity, but due to the strong relationship between HFpEF and obesity, 99% of patients in these trials had overweight or obesity, and over 80% had obesity defined as a BMI greater than 30. So the meta-analysis therefore includes all patients in the STEP HFpEF trials, that's about 1,100, plus those with heart failure with preserved ejection fraction from the SELECT and FLOW trials. The average age of patients in this meta-analysis was 64 years. The primary outcome was CV death and first heart failure event, like it is in all heart failure trials. The results were that about 17% of patients in the 4 trials, that's 3,700 patients, had a history of HFpEF. About half of them got semaglutide, the other half got placebo, and the results, semaglutide reduced the risk of CV death or worsening heart failure events compared with placebo. It was 5.4% versus 7.5%. That hazard ratio is 0.69. Confidence interval 0.53 to 0.89, a significant p-value. So the absolute risk reduction in a composite heart failure endpoint was 2.1% with semaglutide. That's an NNT over the trial of about 47. Now, if you break down the composite, the authors saw no statistically significant difference in CV death, though it was numerically lower in the semaglutide arm, 3.1 versus 3.6%. I'll come back to that. In the subgroup analysis, semaglutide did very well in patients with a BMI greater than 35. Here the hazard ratio was 0.49 versus BMI less than 35, hazard ratio 0.96. The P for interaction of that subgroup was significant. There was, however, no interaction based on the use or non-use of SGLT2 inhibitors. The side effect profiles were similar, except for hepatobiliary disorders, which were about double, 1.4 versus 0.7 per 100 person years. My comments: this is a fairly strong finding of heart failure benefit. But first, let's go over the limitations, which the authors did well in the Lancet manuscript. Of course, this is a post-hoc study, so it's hypothesis generating. The trials had different entry criteria, different follow-up, different endpoints, and even different dosing, which was lower in the CKD study. There were low numbers of CV deaths, which makes it hard to conclude much about the lack of CV death benefit. A large trial would be better. But these were all fairly similar patients. The heart failure reduction is clinically significant and it's statistically robust. And it doesn't matter why it occurs. It's likely through weight loss. The important point is that there were fewer heart failure events, not why there were fewer heart failure events. Now, whether this is enough data to warrant approved indication for HFpEF, I'm not sure, but it seems like a reasonable use of a meta-analysis. The subgroup finding wherein those with the highest BMI had the greater reduction in the primary outcome could be noise like any subgroup, but it also seems highly plausible that patients with more profound obesity would benefit more. And I say this nearly every time I discuss these drugs, but I will say it again. I wish we could implement equally robust weight loss programs with diet and exercise. But the fact remains that few patients achieve GLP-1 agonist level amounts of weight loss. I would also remind everyone that when we treat patients with HFpEF, we are usually treating older adults with multiple comorbid conditions who have been admitted to the hospital previously for heart failure. That is a lot different than using these drugs for weight loss in younger, otherwise healthy people. All right, final topic today is some more previews. I wrote a preview column on 5 trials at the ESC. It's up on the website. Take a look. There are some biggies coming. ReShape heart failure. This will be the 3rd trial for transcatheter edge-to-edge repair of secondary MR and heart failure. Recall that the MITRA-FR trial was negative and co-op was strongly positive. ReShape heart failure will be a very important addition to this space, though the authors of ReShape have selected not 1, but 3 primary endpoints. There will be a trial called sham PVI. This is the first proper placebo-controlled trial of PVI versus placebo or a sham procedure. Now, the problem in sham PVI is the choice of endpoints. The British authors chose AF burden, but we know that PVI reduces AF burden. The question is quality of life. They will measure quality of life only as a secondary endpoint. And I want to say that even though I have long advocated for a placebo-controlled trial in AF ablation, I've also been on record saying that I think such a trial will likely be positive. The question I have is not that AF ablation is a total placebo. It's not. But rather, how much of the effect is placebo-resistant? Later this weekend, we'll also hear the results of the FINE-HEART trial of the non-steroidal mineralocorticoid receptor antagonist finerenone in patients with heart failure and mildly reduced to preserved DF. The company that makes the drug has already announced that it's a positive trial, and at the meeting we will learn the clinical relevance and statistical robustness of the results. And there are many, many more trials coming, and it'll probably take me 2 or 3 podcasts to cover them all. Next week will be a big review of the major ones. I'll also write up some of these trials in written form as well, so take a look at the website this week. That's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review. Let me know what you think. If you disagree with anything I said, go to the website, write a comment. Until next week, this is John Mandrola from theheart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.